First off, questions. So if you have any questions, normally we'd ask you to raise your hand. It'll be more efficient if you actually just type your questions into the area where you can chat and send them to us. We'll try to answer them either on the fly, or we have little time points where we can actually stop to get questions. And we recognize that a lot of this is shared knowledge, shared thinking, and we'd love to hear your comments, your thoughts, your questions about this. So please feel free to do that. We have joining us today probably about 100 people. So if we don't get to your question, we do apologize. We will try to answer them and put all the answers to the questions on the website along with the webinar. So let's get started. Do you mind transferring control back to this computer? I do. Perfect. All right, so we're going to be talking about competence by design and workplace-based assessment in residency. So the ground rules for the session: this shouldn't be us talking to you about competency-based medical education. This is a conversation about how we're going to move this forward in Canada with all of you participating and helping us. There's an expression that there are no dumb questions. I think that's wrong. I think that the dumb question is the one that wasn't asked. There's a good chance that somebody else in the audience has the same question, that it's valid, that it's important, and there's a chance that we didn't explain something very clearly and it needs clarification. So please step up and give us your questions. So why competency-based medical education? Aren't we doing a good job? So if you imagine, there are many countries that are actually coming to learn from the Canadian experience. We have people coming from the Middle East, Saudi, Kuwait, people coming that we're helping in China, people in Latin America, and people are really looking to the Royal College for their leadership, for their educational practice. If you look at most of the physicians that are out there in practice, they're really very good. And if you look at our residents, they're actually, for the very most part, they're really good residents that are really people that you're proud of. And we offer good quality healthcare, so why bother changing? And I think there's a couple of answers to that. One, and I'll have you all think about it in your training programs that you work in. Think of all of the residents that you work with and all of them that have graduated, and think if you would allow every single one of your graduates to take care of someone in your family. So your father, your mother, your sister, brother, son, or daughter. And would you allow that to happen for common things in your specialty when you are 1,000 kilometers away and it is your husband, wife, someone else that's actually there with your family member? And would you feel comfortable with that, or would you want to ask for somebody else? I think the culture of failure to fail is predominant, or not predominant, but exists within our residency training, where people who are not well qualified can actually get through our residency training programs. And I don't think that that is the reason to change to competency-based medical education. I think those individuals we could actually identify pretty easily in today's training without having to restructure the entire training format. The reason to go to competency-based is that failure to fail, or that bottom 2%, is actually just the tip of the iceberg. I think that many of our trainees don't actually get the quality feedback and the opportunity to improve so that they meet their maximal training. And that's what we're aiming for. We know we're on one peak right now and we're doing really well, but our target is to move it up, get to the next peak, meet society's needs, and really train high quality physicians that remain high quality throughout their careers and that we can trust in. So competency-based medical education, it's outcomes-based, it's related to design, implementation, assessment, and the evaluation of programs using an organizing framework of competencies. A lot of words. This comes from the Royal College led process in the International Competency-Based Medical Education Collaborators, which is being updated and will be published again in the next year. But this is the basic understanding of it. Really, what's it about? It's about a better way to train health professionals. We want everyone all of our trainees to achieve their maximum potential, and I think that's what we're really aiming for. Many of you have seen this competence continuum. At the bottom end of it, you see that people get their medical diploma. They move into a transition to discipline, which is really just an orientation, an assessment to the specific discipline, and then they'll go through the foundations of the discipline. That's sort of equivalent to what we've previously referred to as a junior residency. They'll move on to the core of the discipline and ultimately to the transition in practice, and that's similar to what we've had as senior residents. Now, one of the big differences that you'll notice is that the Royal College examination doesn't fit at the end and doesn't fit with the certification time point. It actually comes at the end of the core of the discipline, where residents will have a time period afterwards where they're transitioning to practice under greater autonomy and really refining their skills so they can become a very competent physician that goes on an independent practice. And that final certification that comes from the Royal College is based on having passed the exam, but also based on having completed the transition to practice phase in the residency programs and reliant on the programs to determine how people are doing it to get them through. So that's one big important point that we think needs to be emphasized there. Transition from any stage to the next one is a decision point that's made by competence committees, and we'll talk a bit more about those later on. And it's not put entirely on a program director, and it's not as we have our current training programs and our promotions committees, but we hope that this will be a more robust manner and a better way of assessing change to stages. So why do we, or how will we have people progress through stages? We'll be using milestones and entrustable professional activities. Ideally, the resident will be assessed against the entrustable professional activities to say that they've met them. The reason not to use milestones is the milestones are really well written, but there are hundreds of them, if not over 1,000, that can actually come up into residency training. So we want to get some entrustable professional activities that residents can achieve to show that they're moving from one stage to the next. It helps in the sense that it is progression of competence, and it clearly defines the path of where residents need to go. It's an authentic assessment that's really based on what they're able to do, and we'll talk about that a little further on. It provides a more comprehensive curriculum, and it defines what the scope of the specialty really is, and what are the critical elements that people need to learn. It also provides faculty with some guidance and some benchmarks against which they can judge the residents, and helps them think of it in that framework. To me, one of the key things that has to come out of this is that it's learner transparency and learner driven and learner centered, so that our residents, who are actually remarkably bright individuals for the vast majority of them, can actually see what the targets are and can try to really achieve those important milestones in their growth so that they can achieve competence and get feedback on their performance so that they can continually improve and get better. And the last thing it addresses is that failure to fail culture, where we know currently from the postgrad dean offices that most people that get into trouble for their remediation and other academic problems tends to happen towards the end of the training period, so fifth year of training for many specialty programs, where the problems were actually identified much earlier on but just weren't dealt with. In a competency-based framework, they must show competence before moving from one stage to the next. So we'll identify people that are having difficulty earlier, get them the help that they need to, support them, help them to grow for the most part. And then those that are unable to grow in that way will actually be filtered out much earlier than at the end of residency training if they've somehow perhaps chosen the wrong specialty for themselves, the wrong field to work in. So those are the rationale for using the competency-based framework and how we'll be using milestones and EPAs to do that. So we're going to stop here as a natural break point to see if you guys have any questions that you'd like to see answered, and go ahead and type them out for us.
So Farhan, it's Andre St-Pierre, and just as you were talking about EPAs and milestones, now who has been actively working to develop these for the early adopters for some of the disciplines that are going to be going to competency-based medical education in the next few years? Basically, what has been more or less the process and who's been involved in this?
So thanks, Andre. So to that question, the people that are really developing the entrustable professional activities and mapping them to the generic Candidates 2015 framework and milestones within there, plus adding their own specialty-specific milestones, are really the extended specialty committees that are the volunteers of the Royal College. Now they're working with the members of the specialty committee and all of the program directors, as well as the college, to define what those key competencies are, those key entrustable professional activities that really need to be met before they before people can go on between stages or go on to independent practice. The process has been for the college is that we've started with 2 specialties as early adopters to pilot this, and what we've done is we've brought them here to the Royal College, and they've done work in between defining what the entrustable professional activities are and sort of that pathway to becoming competent. That work has taken already 2 face-to-face meetings and likely a 3rd, as well as work in between those sessions to really move us forward. And it's a period of 2 years for each specialty that we've been working on this. So that's the process in a nutshell. And if people have further questions, I'm happy to speak about them at another point offline. But I think that's kind of what most people would want to know.
So, Farhan, this is a work-based assessment webinar, and I know that part of developing EPAs and milestones will also come with a suite of assessment tools or tasks further down the road, and I know you'll cover that during your presentation. But is assessment really going to be one of the critical pieces of this for evaluating the EPAs and milestones going forward, and how critical will a good assessment program be to the success of this program?
Right, so we're going to talk about in the next few minutes, we're going to be actually talking about the programmatic assessment and how we're trying to support programs, support universities in a manner that makes this authentic and makes this really usable for people. We think that we would like to use the collective wisdom of the country to come up with plans and come up with something that can work for everyone in every training program. And we'll speak to that a little bit further coming up.
All right, I've got a question from our attendees. So tell us how we're going to be supporting and communicating with the frontline faculty, residents, the administrators, and the dean's office. What are we doing in reality to engage them and really support them as we roll this forward?
So great question, and I think this is something that's fairly complex, but the key element is going to be to get competency-based medical education, competence by design, to the frontline clinicians and to the residents so that they understand how it works and can really implement this. We're trying a few things. One is to make sure that what the residents are using is simple, easy to use, is something that resonates with them and that they value in terms of the feedback. We'd like to create tools that the frontline faculty find intuitive, that they're able to use right off the shelf, and that if they need training, that it's sort of that minimal, just-in-time training, that they get little pieces of information on for the first few times that they might use an assessment tool. And we want things that are really quite simple for that frontline faculty person, or frontline teacher to use. We think that they're critical to the coaching of the residents to help them get better. We don't want to burden them with unnecessary tasks, but rather have them concentrate on the things that are the most valuable, most high yield. In terms of the postgraduate offices, we've actually gone out to now, we've been out to every university in Canada just about. There's a couple of last ones that are still being scheduled, and have actually talked to the program directors, have actually gotten feedback from the postgrad offices, and will continue that communication over the next couple of years.
Farhan, one more questions from our audience is, some junior residents actually do very fine because they're less autonomous and there's more supervision at their stage of training. The issue, though, typically arises in a more senior resident who is expected to be more autonomous and lead a team, so might not be able to pick up on all these residents at an early stage. How would CBD or these assessments allow us to maybe pick up on that potential issue at an earlier stage in training?
So I think that's actually a great comment. I think that there are some people that are just, you're not going to pick up because they don't have that ability to, or they don't have that responsibility yet. And that's fair. And I think those ones, if we capture in their senior years, in their foundations and their transition to practice, I think that's completely appropriate. I don't think that competence by design will get rid of that problem entirely. I do, however, think that a lot of our residents, when you really go back into it and you look at their assessments, their even their IDers for for how good those can be in many places, you actually do see the trends and the issues already showing up. And there are clearly a subset of residents where in their final year they're put on probation or the problems are brought up, not because they're newly identified, but just because we finally had the gut check and had to say, this person's going out in independent practice and we really can't let that happen, and then was brought out. And it wasn't brought out because of a new issue or because they were brought to higher responsibility, but it was actually a time period where we just said, look, this is so bad that I cannot let it through. And I think that speaks poorly of us in the sense that there probably are other people, that might be the tip of the iceberg, or there might be other people underneath where they weren't at their optimal, but we do let them go through just because we have to, and we don't have the paperwork to say there were issues. Competence by design helps by having the paperwork, the assessments that are done, authentic feedback, no surprises with an assessment at the end, just really small, frequent, low-stakes assessments that help the person to grow and really give us a big picture of the individual.
Farhan, one more question before we move on, and again, a very good question coming from our audience. It's been mentioned previously that CBD is a transition, not necessarily time-based. In other words, we're moving through stages of training. So typically not a normal program, let's say a 5-year program with different stages. I guess the question is that if we have a resident that actually takes longer, we've identified that they require additional training, and given our current funding model, who and how are we going to pay, or who's going to pay for the extra salary that resident might need? And tied into that is, are we thinking of imposing a maximum number of years for a resident to be in a training program? So what are your thoughts on that?
So I think those are really great questions. And I think the reality of it is that competence by design is not likely to be a time-free training program. What we're going to have is a hybrid model where there's a expected period of time that people are going to be in training. We're not going to be able to go to the ministries of health and say we're going to extend residency training for a prolonged period of time. On the plus side, for the smallest experiments that have been done in competency-based medical education, we've been seeing a reduction in the time period that people have taken to go through things. What really fundamentally happens from an assessment point of view is that the number of relevant assessments of somebody's performance in the clinical setting increases probably by 5 or 6-fold. Those assessments are much shorter than an IDER, much shorter than a broader picture assessment. There's just a single snapshot point in time that gives feedback to the learner that helps them to actually improve. And at the end of the day, I think that's what most of our residents want, is they want to get better. And if they get good quality feedback like that, they actually do. So, the experience thus far has been positive, that it hasn't been extending training. And I think that if we keep our minds about the curriculum we develop, the training programs we put in there, that there won't be a significant number of people that are actually extending out. And I do think that this is somewhere where the postgraduate deans, the college, where we may be having to define, rather than failure to progress, or rather than failure and remediation, what defines failure to progress, where somebody wouldn't be allowed to move from one stage to the next because they're taking too long. And I think that's something that we really do have to start to think about, because that's important from a Ministry of Health and public perspective. Right. So I'll move on a little bit, and we'll stop again for questions in a few minutes. And so keep them coming. Assessment, I think we currently think about assessment a little bit too much as a point-in-time examination. And I think we have good assessment structures within Canada that are a high-stakes examination from the Royal College, examination at the end of medical school from the Medical Council, and we do have in-training assessment via the ITERs and in-training OSCEs and other pieces of information that people do use. What hasn't been done is to put that together in a programmatic manner. So if you imagine these people looking at the elephant, every single one of them will come up with a different conclusion of what the elephant is, unless they can piece all those little pieces together and say, this is what I'm dealing with, this is the elephant in the room, and to put that all together. And so if you imagine it from a patient perspective, if you're working in a intensive care environment or inpatient setting, you could look for the perfect tool to measure serum sodium, serum potassium, and if those numbers are 4.0 for potassium and 140 for sodium, you would say, hey, those numbers are accurate. But that's just one biopsy in health. You wouldn't say that the person is healthy because they had those normal numbers. You'd want to look at their cardiovascular system, the respiratory system, the hematologic system, infectious disease, and on, and to say how the patient is doing overall. Same thing for the learner. You can't just look and say they have excellent medical knowledge based on written tests. You really do need to look at their communication skills, how they collaborate, what are their health advocacy, the professional conduct. Are they a scholar in terms of developing research, teaching themselves? How are they in terms of their leadership skills and how they manage environments and their medical expertise? So there's a lot more to it than single exams, and I think we really do have to take a step back and develop assessment programs rather than individual assessments. And we have to worry about the validity of the program in determining competence rather than focusing on refining any particular single tool that somebody would be using. So there is no single best assessment tool, and we'll need to get multiple tools together to really get an overall impression of the learner. And we're going to try to do that assessment based on the trustable professional activities that will be developed. That's going to take a lot of work in terms of blueprinting. And I think that work is going to be done by this extended specialty committees with the program directors, conscious of what can actually be done in the clinical environment, and say this is something that's reasonable that all programs can implement. And it's something that we hope will get that better feedback and better feed into a assessment competence committee to help with that. So in order to do that, we need an organizing framework. You've all seen the CanMeds framework. We have an arrow in for leader instead of manager because I think most of you know that that's the way that the Royal College framework is going towards. And I would ask you to all come to ICRE in Vancouver and this fall to see the new CanMeds 2015 framework and to see the new CanMeds 2015 diagram. As we were talking about, assessment does have to move away from the testing environment to assessment of people's performance in the clinical environment. No longer do we want to focus entirely on what somebody knows or what they know how to do, or even what they can show how to do in a simulation or an OSCE. We really do want to focus our assessment on what do they actually do in clinical practice. How are they in terms of their communication skills? How do they work with the healthcare team? The skills that they learn in their residency are likely sitting with them for the rest of their careers. So for those of you that are interested in these types of paper, David Ash in JAMA looked at obstetrics and actually looked back at practicing obstetricians and traced back where they did their residency program and found that those that trained in the top residency programs actually had the lowest complication rates, and that those complication rates lived with that obstetrician for the rest of their career. It approached the complication rate of their center, but really it was influenced by where they trained. The opposite direction, those that were training at the poorest institutions that had the highest rates of complications, that lived with the obstetrician for their career as well. So we really do want to think about how do we optimize training so that we launch physicians in a good place, able to improve and assess their clinical performance, and that's going to be critical to this. The ways that we can do that, there's a few ways. The most common one will likely be more direct observation of performance by staff physicians with very quick, usable tools that they can implement. So for a surgeon who's already worked with a resident in the operating room to actually give them quality feedback, document that, and how they perform, how they do that. Emergency medicine, as they resuscitate someone in intensive care, the same thing. So it's really trying to put that into the workflow of what already happens in the clinical environment and to do it in an authentic manner. Some of those assessments will also be how they perform in relation to other healthcare professionals and the public, so to get that multi-source feedback. And then the other things that we'll look at the do level of, or does level of Millers, is to look at work products and projects. So things like their research work, things like their dictated consultation letters, things like their dictated operative reports, and to get them feedback on that and to assure that they've hit the bar. Next slides talk about the learning, and often as educators we think about the curriculum and we think about how to optimize learning by building curricula, and we get interested by that, we get excited by that, and we spend a lot of time working on our curriculum. Now I'll ask everybody to think back to their university years and perhaps to their own Royal College examinations and think about what drove their learning. And it really is that the assessment drives the learning, and that is a reality of every student that we're dealing with. Now, we should have figured this out a long time ago, but what we really need to do is to think of assessment as part of the instructional design and to design our assessment so that it really aligns with the curriculum. If we can do that, it doesn't matter why the learners, the residents, get to the point that they need to. It's that they do actually get there. So we've got to tie our assessment to the curriculum, to the authentic things, and to make sure that people get to where they need to go to. And that's something that's fundamentally different as we're designing competence by design with the specialty committees, is that we're already thinking about the assessment right as we're thinking about developing the pathway to competence or the curriculum that people need to take. I'll stop there and see if there's any questions related to those things.
Farhan, just a quick question. Just revisiting our earlier discussions on EPAs and competencies and milestones. With respect to internal medicine training, how will the CBD and EPAs for our Canadian trainees compare with the ABIM and ACGME guidelines? Are we going to be in parallel or learning from those, or what would be your thoughts on that?
So I'm going to take us back a few slides just to show us the competence continuum. And I'm hoping that I actually clarify rather than confuse people on this one. So please feel free to send an email if it's not so clear. If you look at our competence continuum here, we are not going to be using EPAs in the way that most people are thinking about them. The way that the American system and many other places think about EPAs is that you can only have an EPA at the when you're transitioning to practice as you're stepping out. So it's really that terminal end of training EPA, and you build towards that. We're designing our competence by design in a slightly different way. So we'll be referring to our EPAs as sort of Royal College EPAs. And there will be EPAs that you can actually achieve at transition to discipline, foundations of discipline, core of discipline, and transition to practice. And we'll be looking and assessing those EPAs to make sure that you've hit those prior to moving from one stage to the next. In some instances, that EPA is going to look the same. So as an example, and remember this is just an example, but let's suppose that we expect all residents in intensive care to be able to run a resuscitation at the foundations of discipline stage. And I know this might not be true, but let's, for hypothetical reasons, let's imagine that. Then that EPA is done at that stage. We'll want to check that it maintains being done in the core discipline and transition to practice, but it's really done there, and it looks the same from there onwards to a physician in practice. There will be other EPAs that may be, in our language, developmental, and they may feed into future EPAs. So as an example, and this is more of a milestone than an EPA, for us an EPA, an entrustable professional activity, involves multiple CanMeds roles, and in order to be called an EPA. But let's consider there's a milestone of the mechanical act of intubation, and that milestone may be achieved at transition to discipline. So yes, you've ticked that off, you've achieved it, and it feeds into the ability to resuscitate a patient later on. So that's the difference that we're having. So that the many other models will only have entrustable professional activities at the end and look at progression towards those all the way through. We will actually have entrustable professional activities at each stage of training, and that the resident must hit those entrustable professional activities to move from one stage to the next. And I hope that's clear rather than confuses.
Farhan, in today's world, from Royal College perspective, we have our Royal College examinations, which is really our formal assessment, if you wish, prior to certification. With the advent of milestones and EPAs, do we envision that the Royal College will have other assessments between these tools other than our final summative assessment?
Right. So that's a great question, and I think what we're doing is working with the specialty committees to define what the right assessment strategy would be. At the current point in time, we don't have any intention of increasing the number of high-stakes examinations, but we do think we have a role in defining what the entrustable professional activities are and what the assessment strategy should be. Hearing from program directors, and having been a program director up until recently, one of the things that's frustrating and challenging is that you run a program and you rebuild everything and reinvent the wheel at your site for your specialty program, and it's different than everybody else in the country. And how can you leverage your colleagues across the country to have a national standard and use things and share things so that you're not redoing all that work and can repurpose your time to doing the most relevant things in your environment. So one of our hopes with competency-based medical education is that we'll have a national assessment strategy that people can use, that's going to be developed by the specialty committee and the program directors, that's usable, that's authentic, that is something that can ask the clinical teacher at the bedside to fill out a very short assessment point, and that will feed into a competence committee that will make those decisions. And that we can use that information in a more rational manner and spend the program directors and the residency training committee's time in other ways so that there is this developed. Now that doesn't mean that there's not room for innovation and room for development, where people can actually say, you know what, I see what we have for a national standard, and I'd like to innovate around that, and I'd like to work with the national the specialty committee to do that, or I'd like to do that locally and pilot it and work on a particular tool. We'd actually, want to have something where there's more creativity around things. But I think if we have a national assessment standard and we know that residents in programs are hitting those milestones, EPAs, and that they're passing from stage to stage, that we can actually allow more liberty on the curriculum side and innovation to the program so that they can be more creative, that they can use their local resources and change things, just as long as they know that the outputs of their program, their residents are graduating with what they need. The other really nice thing that it allows, if I'm thinking from the program director's standpoint, is it allows me good, high-quality comparative data. Almost all program directors I've spoken to have said, I'd love to know how my candidates do on the Royal College exam. Could you imagine the situation where you're not only able to look at how your candidates do on the Royal College exam, but rather you're able to look and say, how do your candidates do or your residents do compared to national standards? And what are their areas of strength that you're really doing a good job in? And what are their areas where you might need to work on as a program? And looking at that to try to improve your program. There was a series of papers on assessment published after the last Ottawa conference, and one of them talks about what constitutes good assessment. John Norsini is the primary author. And I think one of the things that we forget about as being good assessment is its catalytic effect on the training system. And I think this gives us an opportunity to do some comparisons if people are assessing the same ways to say, hey, you know what, we're doing great in the cardiology areas, but we might want to work on nephrology in our pediatrics residency. See if there's any other questions.
Yeah, Farhan, I've got a few more questions. So what role do you see for in-service exams, exactly like the ones that are administered by the ABIM, in training and evaluation?
I think the in-training assessments are really part of the assessment for learning, right? That is something that can help our candidates improve. It can actually give us one little biopsy into how their performance is, but really can show them where their strengths are, where they can work on things. We will have to see in terms of the specialty sizes what can actually be done with different specialties. But there are ways that we can perhaps combine resources. So for instance, in pediatrics, they're working on developing OSCEs so that each center doesn't build an entire 12, 15 station OSCE each year. What they do is they develop one at each site and they share so that everyone's got a national OSCE and they can use that information. And that's something that we can actually leverage technology, leverage people working together, and come up with something that's useful.
Farhan, one more question before we move on for this presentation. So current writing on EPAs indicate that 20 to 30 EPAs for the entire course of postgraduate training is appropriate. The idea of college EPAs for each stage of the competence continuum would be extremely large. What are your thoughts on that?
So that's a really good question, and I think this is, even that 20 to 30 numbers, just sort of early thinking by Ole Tinkate and colleagues. And the idea I think here that this is representing is not necessarily the 20 to 30, but rather what's the right size of an EPA. If we get them to be too big, then they become really hard to assess and really hard to look at. So, if you end up with 4 or 5 EPAs, they're likely to be giant. It's going to be really, really hard to pull data together to say that they've hit that EPA. If you make them too granular and you end up with 100 of them, then I think what you end up doing is you end up having people focus on micro areas, and there might be actually too much information to be assessed. So I think there is a Goldilocks spot that's the right number, and that 20 to 30 might actually be the right thing. We do believe that it's going to be at each stage that there's going to be a certain number that is going to be the perfect or optimal number, and I think that's really going to depend on the length of the program and the length of the stage. So I don't think we can paint it with one brush, because I think internal medicine, foundations, and core will look a lot different than a subspecialty like critical care that only has a much shorter time frame. So I think we have to be conscious about that, and as we build our competence by design programs, to think about that as we develop it. And so I think that's a great question, but I think it's a little bit of the to be determined piece. So we'll move on a little bit from here. The wisdom of crowds. Right now, there likely is too much pressure on a program director to make decisions around competence that may not be fed into the proper type committee structure. And the wisdom of crowds is actually really quite important in determining competence. Every program has a residency training committee or program. Many have a promotions committee that's separate from that or slightly different than that residency training committee. What we're advocating for is a separate committee from the residency training committee that's a competence committee. It's a little bit arm's length, not chaired by the program director, that is actually looking at the competence of the resident as they progress through. And their job will be to look and say, look, are they meeting all of the addressable professional activities at this stage before they go through? The other nice things about the collective there is that they may actually be able to identify residents that are doing superbly well, where in later time frames you may actually say we can we can modify their program because they're doing great and they have an interest in X, and we'd like to encourage that interest, and you can modify the program to meet that. We don't see competence by design wreaking havoc with the healthcare delivery system, in that we don't expect somebody to say, yeah, they've hit the EPA today, therefore tomorrow I have to change their rotations. That is just not workable. We need to have a system where those competence committees meet at a regular interval, minimally every 6 months. But as they're planning the yearly rotations, they can start to think and say, you know what, these individuals are doing great at these things, and we can encourage them by giving them these challenges. Or these individuals are having challenges and difficulties, and we may need to focus them in particular areas in our upcoming yearly schedule. The wisdom of crowds helps in other ways as well, in that, and for those of you that are program directors, this will resonate with you entirely, so we often get those professional conduct issues told to us in the back hallways. I just wanted to let you know that I interacted with so-and-so and this came up. And so rarely do they actually put that down on paper. Or you get a lot of people that are working with an individual and say, you know, there was something off, but I just attributed it to them having a bad day. Maybe it was me having a bad day. I didn't really write that down. It wasn't really an issue. When you put groups together, those things actually do come out. And there's literature to support this, that when you have those discussions, you actually do pull out some of those professional conduct issues. And if you think about our challenges with our current residency training structure, one of the big challenges, at least to me, is that individuals that have professional conduct issues can have them right from medical school, right through residency, and then continue on right into practice, and we don't actually address all of those issues. So I think that's a important thing that we have to think about. Another key element there is the handover of learners. It is, from the public's perspective, not likely okay that we allow residents to do things without actually really knowing where they stand. So if you start and you've never worked with a particular fourth year or fifth year resident, and you're allowing them to put in a central line just because they're a fourth or fifth year resident in internal medicine or pediatrics, that doesn't quite make sense. A competence framework would tell you that, you know what, I know that this has been assessed, I know that the stages they've gone through, and because of that, I'm getting some information about this individual before they come to me. And I think that's really critical. In an ideal world, we would have a setup where learners work longitudinally with individual physicians or groups of physicians where, you know, they get feedback constantly, we see development and growth. But that doesn't work in our current setting. And so we need to find better ways of making sure that the issues that are found early on are addressed, and that strengths that are found early on don't have to be reassessed, can actually be built on rather than bringing them back to the baseline. Faculty development, and I kid about this as the Achilles heel of competence by design. I think it's actually the thing that we have to think about the most. And it's not only the faculty development, but how do we support our faculty in order to deliver high quality training and high quality assessment that changes from, you know, in many residents' mind, from the punitive system that it is now to a coaching way where residents value that feedback so that it helps them get better, and turns into a method of, it doesn't matter how you got there, you want to get the feedback so that at the end of that time frame or that stage, you've hit the important milestones, EPAs. So you want that feedback early on so that you grow and get better, so that when it's time to really judge how you're performing, that we actually can do that, and you've clearly hit the bar and the mark. So you really want that feedback to get better. Some of the things that we're thinking about is just-in-time tools to help people with the assessment instruments, using instruments that are really intuitive to the faculty rather than our current tools, short assessments, you know, in the moment, quick, rather than done weeks to months later when you've already forgotten what happened. So really, in the moment, I saw this happen, ties into my workflow, and then I can access and do this without having to do it on, find the piece of paper that I'll never find, or get to a computer that I have to then log in for. But I can just use my iPhone, my Android, my iPad, and just do this in that moment. And I think those are the types of things that we're thinking about to help faculty. And I think we still have to do on top of that, help them to understand the culture shift and what we're going to. Another key element of competence by design is the promoting reflection. And I think this is a key element that we want to bring in there and that we're using our portfolio, e-portfolio, to help do. If we imagine residents are with us for about 5 years, maybe 7 if they're doing fellowships, but they're with us for a short period of time. And we want them to be able to reflect on their learning needs, their performance, and be able to improve for the rest of their lives. And that's a critical piece that we think has to happen in residency. So we need to promote that self-reflection. And we know that people are poor at self-assessment. That comes out of Kevin, Eva, and Glenn Regere's work. But we do think we can actually help people to become more reflective, and with guided self-reflection can actually help to improve themselves. Other things we're thinking about, and this is not something that's planned to come in immediately, but something that we're contemplating, is an external lens to support competency-based medical education. And what I mean by that is we currently have the assessments that are all done within one training program and looked at by one residency training committee that all is working on themselves. What if we had an external lens on the competence committee? So could it be a program director from another institution? Could it be a program director in a different specialty from the same institution? Could it be a public member that would help that residency or that competence committee think through the competence of that individual learner and help do it in a fair manner? And this has been piloted in different areas. And it's something that we're contemplating that I think may actually change the conversation that happens in those competence committees and keep us true to ourselves. And as a parallel, if we think about what happened in the hospital system around patient safety, as we started to engage patients, we can actually see that we opened up more. That transparency actually helped us to improve our individual practice. So this is something that we can think about. In my mind, I almost wonder, and this is dreaming in Technicolor, but if our residents would leave our program and then go to another program to be assessed for a 2, 3, 5, 6 month period, how that would actually change our own residency programs. If I knew that all of my trainees would go to another university and be strictly to be assessed, I could guarantee that we would make sure that our residents were at their absolute top before we set them out because they represent our program. And I think that's something that we kind of are thinking about. Thinking about narrative and subjective, I'll use an example that's outside of medicine. But if you take a second and just think about what makes a really good hockey player, and think about only objective, measurable things that you can look at that makes a hockey player. So you might think of things like skating speed, slap shot, their strength, their size, and you come up with some objective criteria of what makes a good hockey player. Now, if I flash up to you the picture of Wayne Gretzky and ask you to judge him based on his speed, his size, his slap shot, the accuracy of his slap shot, you may actually think and say, wow, he really doesn't look very good compared to most NHLers. And yet, most of us would agree that he was one of the greatest hockey players of all time. And I think that's something we have to think about, is that the subjective impression is actually useful. Experts thinking subjectively can actually be really helpful to people to understand where the issues are and to help people improve. The other key element around that is the use of narrative. Assessments, we score them and we reduce them down to a number, but that's not natural. A particular performance is not a 2.5 out of 5 or a 3.5 out of 5. Those numbers are slightly artificial constructs so that we can actually look at this and score them and see how people are progressing. But a lot of valuable information comes in the narrative comments. And if you think about your evaluations as teachers, you can always see that you're performing well because your scores are on a 5-point scale between 4.2 and 4.7, and they consistently sit there. But that doesn't give you something to work on and improve on. And it doesn't tell you how you really feel you're doing. So you often look down at the comments first and say, well, really, were there people that thought it was excellent? Do I have constructive feedback that I can actually work on? And I think the same goes for our learners, and we need to implement that narrative. You can see in the slide, you can tell what that word is. It's competence. And what this is there to illustrate is that we don't need to measure every single piece of things. There can be, if we've got a big picture that somebody is progressing okay, we don't have to measure every single thing. And we can assume that it's going the right direction. Just like with your kids, as they're developing, most of you will know, if they walked at an appropriate age, they put two words together at an appropriate age, they sat at an appropriate age, we don't look at the 100+ items that are on a Denver developmental scale. Because the big picture things are being met, we assume that everything else is going on. If there's something to worry about, you open it up and you do more assessment or more things to look for more pieces of information. We do exactly the same thing in our clinical environment. If you think of, and I'm going to ask you all to think of what the diagnosis is here, and think to yourself when you have it. A 5-year-old boy comes in because his mom says he's peeing a lot, and he's actually drinking a lot. For those of you who have the diagnosis now with one simple urine test, it's clear. And we stop at that point and say, okay, we've made that diagnosis. When it's more confusing, it's a 95-year-old on 23 medications, is coming in with weak and dizzy. What's the chances that we're not going through an extensive history, extensive physical, and extensive lab tests to try to sort this out? So we do that in our clinical environment. We have to think about doing that with assessment. Optimize flow when people are following the right trajectory, minimize the amount of work, and then when it's necessary, then expand out and do more when that's required. Simulation has been underused in assessment to date. It's been felt that you can only put simulation as a safe learning environment, and that means absolutely no assessment. And that's been the classical teaching in simulation. And I think that was way too simplistic. If you ask our learners, they're actually comfortable with being assessed in the simulation environment if we do it authentically, if we do it in a manner that helps them grow and get better, and if they think that there's value in that assessment for their feedback. And I think that's something that we do have to think about implementing more of. Likely not at our high-stakes Royal College examinations, but perhaps as an entry assessment at the local site or groups of sites where people can actually have to go through a simulation OSCE in the relevant fields. And they have to pass that to come to the Royal College exams. And if they don't succeed, well, they get an opportunity to learn and to re-practice and redo it again. I think this is a key learning opportunity for us as an organization. And the last thing that I have people start to think about is moving competency-based medical education into continuing professional development. The Royal College just hosted a summit that Craig Campbell led, pulling people in and starting to think about competency-based medical education in continuing professional development and how it applies the EPAs, the milestones. How are we going to introduce this? I don't think there's an appetite in Canada to have high-stakes recertification exams every 7 to 10 years. But I think that most physicians, if we actually came to them and said, are there ways that you could assess your own practice, either through patient outcomes, either through comparing to colleagues in practice, or even by doing a focused self-assessment using exam questions of your area of especially your scope of practice that would give you feedback on your performance and knowledge and understanding so that you can try to improve. I think that resonates a lot more with our clinicians. So I will stop there and open the floor up to questions for the last few minutes.
So, Farhan, one of the questions that was brought up through one of our participants was, in the handover of learners, how would you avoid bias and prejudgment based on information through progressions?
So I think that's a great question, and I think that's what I think that's the thing that we've been concerned about in not doing this routinely. There are already models that look at handover of learners, and I think that what we're really talking about is patient and public safety. I think how can we say to the public that we're allowing a learner to do something without actually being sure, allowing them to do something on a patient without actually having been sure that they've hit the right bar. And I think what we really need to do is to have learners have ownership of their learning plans, to have ownership of their assessment profile, and to actually use that to guide their future learning and to come to it with to their supervisors with, these are the areas that I need to work at, and these are the areas I'm actually pretty good at. Get them more responsibility in the areas that they're really good at, and make sure that they're achieving the competencies in the places that they need to. As a patient, or having spoken to patients, they would feel that it's unethical to allow people that we don't know their competence to practice on them without having been sure of them. And I think that's where we have to take the picture from. I do agree that there are issues around biases, that we do have to work around that we do have to find ways that there are fair assessments. And if there are issues around that, how do we get unbiased things? Do we have to go outside the usual training processes? But I think that is a clear thing that we really do need to, as a community, work on. We have a social contract with society that says we only allow people who have the competence to practice, and we need to go back to that.
Farhan, one more question regarding certain aspects of ABIMs. So there's been a lot of discussion around ABIM's recent changes to their MOC program. How would the Royal College's continuous professional development program compare?
So I'm not sure if this question is actually relating to the media attention in the United States about the ABIM and certification and the stuff that was in, I believe it was in Newsweek, and I think painted in a very negative manner. I don't think that's the intention here. I don't think that the college has any ideas around, for lack of a better word, what was perceived as building empires and not there. I think the idea of our continuing professional development is actually, how do we help physicians continue to grow and develop? If you think about it, there are, I think there's at least 10 or 12 randomized controlled trials that are published every day. And how does a physician keep up in terms of new stuff that's growing? From the American recertification exams, what seems to be happening is that what people learn in their residency, they tend to maintain going forward, but the new domains, the new things that are coming into medicine, they don't necessarily keep up with. And I think that's what we have to think about. Medicine is constantly evolving, constantly changing. How do we do things that are going to help our fellows to continue to grow in those domains and to get better and to get feedback on that in a practical, usable manner, so that they're not out studying for an examination and spending a year studying for that, but rather, how do they look at their performance? How do they look at their particular scope of practice and get assessed on that so that they can improve? All right, good. So I know others of you have sent in questions, but it is now at the top of the hour. What we will try to do is to pull those questions together and to answer them and to post it alongside of the webinar so that we have those particular answers there. Again, thank you all for joining us. If you have further questions or you want to talk about this, my name's Farhan Bhanji, and I work at the Royal College and at McGill. You're welcome to find me through the Royal College or McGill, and I'm happy to sit down and have the conversations. I think this is an exciting time for medical education in Canada, and I think that it'll be all of us that help to move this forward. So thank you very much for joining us, and I look forward to conversations.